All right, can you all hear me okay? Excellent. All right, first of all, thanks for the shout out. So as you can imagine, so Matter Bio, we are working on several aspects related to longevity, including DNA repair and DNA mutations and as they relate to DNA repair. But what I'm going to talk about today is our most advanced program. It's a therapeutic focused on cancer, solid tumors specifically. So you may have seen in the news RevMed, Revolution Medicines, came out with a new drug for pancreatic cancer, which got a standing ovation, which was very much deserved. It almost doubled survival time for all those patients. So we are actually working on solid cancers, starting in what's called PDAC, pancreatic duct adenocarcinoma. And we're very excited about the heat that's coming with this, with the RevMed drugs, but we think we can do a lot better. So I want to share more about that. Just a little bit about this. So obviously here we're all trying to prevent cancer. That's the ideal. But if you have cancer, it would be nice to actually be able to do something about it. It's still the lead cause of death, or one of the lead causes of death once we get old. And so that's what we're trying to do. So it's really bad. So how are we doing this? So this is a little bit of a twist. So our approach is bacterial. And there's some implications there that I'm going to talk about in a second. So what we're trying to do, and this is actually relevant to the conversation earlier, the presentation earlier on the thymus aging. As we age, as we've just heard, the thymus starts to exhaust the ability to create new T cells, naive T cells that are being trained to recognize disease, including cancer. And so a lot of the approaches to cancer treatment have been immune therapy. So let's see if we can teach the body to recognize cancer. And so it hits a lot of these different challenges. So what we're doing is we have a bacteria that we've developed that selectively infects tumor tissue and not healthy tissue. And that allows us to deliver all sorts of different things. What we're delivering is tetanus antigen. So this is the rough set mechanism behind me. So we infect cancer cells, we express on those cancer cells tetanus antigen, something that all of us who have been vaccinated in childhood have reactivity to, memory T cells too, so you don't need to rely on naive T cells. And then the body does the work for you. So the body thinks, oh, you have a tetanus infection, well, let's just get rid of that. And it happens to be destroying cancer cells. And one of the benefits of this, which I won't belabor the whole mechanism, but the benefit of this approach is that we're able to infect not just the primary tumor, but all of the metastases. In fact, we're even better at infecting metastases than we are the primary tumor. So why does this matter? Well, for example, in PDAC, most patients show up, 80% of the patients show up stage 4. That's when you start to get symptoms. So you're already metastatic when you're starting to feel unwell. So you need an answer to metastatic disease if you're going to really be able to treat a lot of these difficult to treat solid cancers. So we have a mechanism that allows us to do that, and it's generic to all solid cancers, not just PDAC. So why does this matter? Well, the traditional barriers to treating solid cancers are, amongst a lot of others, the suppression of the tumor microenvironment. So even if you were able to have a functioning immune system, it can't see the tumor. It's hiding actively. You have, in the case of PDAC, what are called low neoantigen content. So a lot of tumors can mutate and are starting to show antigens that are non-self, which is a good thing. Some of these cancers, like pancreatic cancer, don't mutate a lot. And that's bad. So it looks very, very, very close to healthy tissue. There's not a lot of tumor antigens. So you have very low targets and low immune activity. And then finally, the ones that do mutate start to drift away from whatever treatment you've created. And then, like I said, it's metastatic. And then in some cases, there's other barriers. So PDAC has a stromal barrier, which physically stops things from getting to it. And glioblastomas, for example, treatments have to go through the blood-brain barrier in some cases. So there's a lot of barriers that we're overcoming with this technique. So I'm just going to share some data, and then I'll stop talking in case anyone has any questions. So I'll keep this short. So we have, this is all preclinical data. We have some extensive data published showing incredible efficacy in pancreatic cancer-bearing mice. So you can see visually a massive difference in tumor size, and it's also shown in the actual burden of disease on the right. And then from my perspective, so in my opinion, what's even more important than not having tumors is, does that extend lifespan? And we do see a massive extension in lifespan in these mice. So it's worth noting models come in all different types of cancer, all different types of mice. these are mice that genetically generate pancreatic cancer. So you're never going to cure these mice. They are very sick, and they will continuously generate more tumor burden. So this result is very, very significant for these category of mice. It's about a 54% increase, which is, again, apples to oranges, but about 5 years if you were a human. And these were treated very late in life. So most of these mice, you don't want to treat past 8 weeks because nothing works past 8 weeks. These were treated at 20, basically on the cusp of death at stage 4. So to give some context, because we're trying to compare this to emerging standards of care, what you see is how this compares to Revolution Medicine's drug, the KRAS inhibitors, at our current stage. So we don't have clinical data, so we have to obviously prove this out. But at our current stage, we are more effective than what they were in the same types of mice. And we started at stage 4 in the mice, whereas they started stage 2 or 3. So we're able to be at later stages of disease and be more effective. And much more importantly for patients, not just effective, but very tolerable. So these mice have very low toxicity, and this has very high redosability. So we're hoping we're going to see this obviously in clinical. Now, a little bit about the specificity. The red is the bacteria. As you can see behind me, it's very, very selective for tumor tissue and metastases and cleared out immediately in healthy tissue. This is obviously critical. And we then said, okay, it works really well in pancreatic. What if we do the exact same thing, but now do it in refractory ovarian cancer? This is cancer that's now resistant to standard treatments. And we saw very similar results with refractory ovarian cancer mice. And same idea, about 54% increase in survival. And then we said, okay, well, this is a super tolerable treatment. It's not something that you only have to take once. We've done upwards of 12 dosings without any added toxicity. Think of it kind of like when you get sick, like you get a cold or you have, a bacterial infection. There's no real limit to how often you can get it, unfortunately. And we're seeing that. That's the benefit of this. And so what we said is, okay, what if we give them a second treatment? And we doubled survival again. So there's a world out there where if we don't knock this out of the park and cure it completely, you can make it chronic. And then last but not least, we have some early data in glioblastoma. So what you see here on the far left is a healthy mouse. We engrafted glioblastoma tumor cells intracranially. We let them engraft for about 30 days, and then we started treatment. And you can see the effect on the right in one of the mice that was treated. They were completely cured of the glioblastoma. And when you looked at the survival data, half the mice were cured completely, and the other half had a substantial survival benefit. And this is with the same route of administration, same dosing schedule, not optimized in any way for this disease. So we think we could probably start curing a lot more or all of the mice if we optimized it. So this got us obviously very, very excited. This is difficult to do even in mice. So it's one of those just horrible cancers. And then importantly, we saw that the safety is really good. So we did dose-limiting toxicity studies, and we're about 10 times lower dose than what starts to show any type of DLTs. We have excellent biodistribution where you want it, not where you don't. And like I said, we just kept dosing mice to see what would happen, and they tolerated it extremely well. So the other benefit is this has been used previously in clinical studies with humans. So we are guardedly confident that this might have a good safety profile. And this is our timing. So last but not least, we are about to start human clinical trials in the next few months, first in human in PDAC. So we're really excited to actually see now what this looks like in patients. And so the last thing I wanted to say about this is obviously we have to show that it works and that it's tolerable. It'll be a phase 1/2A. If it works, the benefits of a live attenuated bacteria is that it grows itself. So this is something that became apparent as we did GMP for this. We spent enough money to have 20 liters in a bioreactor of that material, which is enough for 1,000 patient doses. And that cost us less than $500 a patient dose today. So you can imagine a world where you could treat thousands or millions of people in a bioreactor grown bacteria that gets cheaper the more you make, just like with beer. So 1,000-liter bioreactors filling this room could treat every cancer patient on Earth. And that really got me going. So this does not have to be a multi-million-dollar treatment. This could be something you could actually give at late stages of disease multiple times for the whole world. And that really obviously got me pumped. So fingers crossed, you'll hopefully be hearing from us about our results once we start getting them. But just wanted to share that and happy to answer any questions.
Do we have time for a question? Hi, great talk. That's really exciting. I have a picky little question about your pancreatic cancer model.
Yeah.
Can you go back to the slide where you do the RevMed comparison?
Sure. Apparently not.
So RevMed started with an earlier stage cancer. Why was their baseline survival so much worse than your late stage model?
That's a great question. So we actually asked ourselves the same thing. So we're like, this looks weird. And the answer is, if you see here this giant flip, it's because on the control especially,
Yeah.
the way they did the study is they actually sacrificed the mice when they had a certain clinical score of morbidity. And so the top ones, our results are just survival.
The mice died on their own.
They just died for both arms.
And their mice were sacked for humane reasons at an earlier, like when
Correct.
they, okay.
When they hit a certain grade.
Great. That was the weird thing about that slide.
Yep. Thanks. Yeah. Thank you guys.